الجول بلادر اند بايل داكت. اخذنا بالبدايه مثل ما قلنا اناتومي سيرجيكال اناتومي جول بلادر اند بلياري جنرال، بعدين اخذنا انفستيجيشن of the gallbladder and biliary، واخذنا الكونجنتال انومالي of the gallbladder and biliary، اخذنا biliary atresia كملناها، ووصلنا الى congenital dilatation of the intrahepatic duct. Congenital dilatation of the intrahepatic biliary tree called Caroli disease. This rare condition طبعا is characterized by multiple irregular circular dilatation of the intrahepatic duct with normal extrahepatic biliary tree، يعني normal left or right hepatic, common hepatic, bile duct, common bile duct is normal, but the intrahepatic biliary tree is dilated congenitally. Etiology is unknown, but it's considered to be hereditary. It can be divided into simple and periportal fibrotic type. The periportal fibrotic type present in childhood and associated the biliary stasis, ومن ثم stone formation and cholangitis. Any stasis lead to the stone formation, and stone formation may lead to the infection of the bile duct called cholangitis. In contrast, the simple type present later on, beyond the childhood, with episode of the abdominal pain, biliary sepsis. Associated condition include congenital hepatic fibrosis and polycystic liver disease. Treatment of this Caroli disease are antibiotic for cholangitis and removal of calculi with the lobectomy may be indicated. Okay, then treatment of the complication rather than the treatment of the true pathology or true congenital anomaly. Another congenital anomaly is choledochal cyst. This is important. The importance of the choledochal cyst came from the associated with the cholangiocarcinoma, associated with the malignancy. So it is important. Choledochal cysts are congenital dilatation of intra and or extrahepatic biliary system. The pathogenesis is unclear. Type 2, type 1, type 2, type 3, type 4, type 5, 5 types. The commonest type is type 1, which is there is circular dilatation of the extrahepatic bile duct about 75%. Okay. Type 2, there is intrapancreatic dilatation of the bile duct. Type 3, there is diverticulum of the common bile duct. Okay. Type 3, there is diverticulum inside the pancreas of the bile duct. Type 4, there is intrahepatic dilatation. واضح? And it is the presentation of this congenital anomaly is at any age. Although it is congenital, but can be presented with the later on. Okay, with jaundice, fever, abdominal pain, and right hypochondrial or upper abdominal mass on examination. Pancreatitis is not an infrequent presentation in adult. Patients with the choledochal cyst have associated with the cholangiocarcinoma مثل ما قلنا with the malignancy, so it is very important. And diagnosed by ultrasound would confirm the presence of abnormal cyst formation within the bile duct. And magnetic resonance imaging (MRCP) will reveal the anatomy of this dilatation. CT also useful for the to assess the extent of intra or extrahepatic biliary dilatation. The treatment of this choledochal cyst is radical excision. Radical excision of the cyst because it is associated with the malignancy. So it is not bypassed. وإنما excision is the treatment of choice with the reconstruction of the biliary tree using a raw NY loop of jejunostomy as choledochojejunostomy. يعني use of loop of the jejunum to reconstruct the biliary drainage to the bowel. Complete resection of the cyst is important because it is associated with the malignancy. Okay, this is the choledochal cyst. خلصت الكونجنتال انومالي اوف ذا بلياري تري، نجي على باثولوجي اوف ذا بايل اند جول بلادر. نجي بالبدايه as trauma. The trauma to the gallbladder and etc. biliary tree are rare because it is small in relation to the other surrounding organs like liver, spleen, okay, stomach, because it is surface area of the biliary tree is small, so it is the injury to these biliary tree are rare. They occur as a result of blunt or penetrating abdominal trauma. يعني blunt trauma or penetrating abdominal trauma. Operative trauma is perhaps more frequent than external trauma. يعني iatrogenic injury to the biliary tree is more common than accidental trauma to the biliary tree. The physical signs are those of acute abdomen. The patient came with a peritonitis with the acute abdomen. Management in a stable patient, transected bile duct is best repaired by Roux-en-Y choledochrojugonostomy and anastomosis the bowel to the proximal segment of the bile duct to bypass the injured segment. Injury to the gallbladder can deal with the cholecystectomy. No repair the gallbladder. There is no need for repair of the gallbladder. Any injury to the gallbladder will remove the gallbladder by cholecystectomy. Another aspect is torsion of the gallbladder. This occurs mostly in an older patient with a large mucosal of the gallbladder. Patients present with the acute abdomen, immediate exploration and cholecystectomy are indicated. The torsion of the gallbladder is very rare when the gallbladder is supplied by mesentery, so it is axial rotation of the gallbladder, mainly torsion of the gallbladder. The patient present with the acute abdomen, and the treatment is cholecystectomy. Now we take the commonest problem that occur in the gallbladder is gallstone, called cholelithiasis. Gallstones are the most common biliary pathology. It is estimated that gallstones are present in 10 to 15% of adult. They are asymptomatic in majority of cases. Diagnosed by another problem. They take imaging for another reason. Approximately 1 to 2% of asymptomatic patients will develop symptom requiring cholecystectomy in the future. يعني ال asymptomatic patient not remain the asymptomatic patient. What are the causes of gallstone? The gallstone can be divided into three main types: cholesterol, pigmented, and mixed stone. 80% are cholesterol or mixed stone, whereas in Asia, the pigmented stone are common. Cholesterol or mixed stone contain cholesterol plus a mixture of calcium salt, bile acid, and bile pigment and phospholipid. What are the pathogenesis of the gallstone? The bile is supersaturated with the cholesterol or bile acid concentration are low because there is balance between cholesterol and bile acid within the bile. When there is this balance is changed, lead to the crystallization of the cholesterol as crystal ومن ثم nucleate to form stone. To obesity and high caloric diet and certain medication like contraceptive pills, the secretion of cholesterol and supersaturated bile increase the lethogenicity of the bile. 3. Abnormal emptying of the gallbladder may promote the aggregation of the cholesterol crystal, hence removal of the gallstone. Without removing the gallbladder, inevitably lead to the gallstone recurrence and formation. Decreasing weight rapidly, especially in operation of decreasing weight like sleeve gastrectomy or bypass that lead to the decreased weight rapidly may lead to the formation of the stone. Okay, abnormal emptying of the gallbladder like tracheotomy, which is last operation that obsolete because it is nowadays is very rare or not done. tracheobligatomy, lead to the abnormal motility of the gallbladder, lead to formation of the gallstone. Pigmented stone is the name used for stone containing less cholesterol. There are two types, either black or brown. Black stone are largely composed of insoluble bilirubin pigment mixed with the calcium phosphate and calcium bicarbonate. Black stone associated with the chronic hemolysis like hereditary spherocytosis, sickle cell disease, or thalassemia, which is common in our locality. Patients with cirrhosis may lead to the higher incidence of pigmented stone for unknown reason. Brown stone, the second type of the pigmented stone, are rare in gallbladder. They are formed in the bile duct that related to the bile stasis and infected bile. Clinical presentation of the gallstone. Patients typically complain of the right upper quadrant or epigastric pain. We may be radiated to the back. This may be described as colicky, but more often is dull and constant when it's continuous, or the complication of the acute cholecystitis will be happen. Other symptom of the gallstone per se without infection or without cholecystitis is dyspepsia, flatulence, food intolerance, particularly to the fatty meal, and some alteration in the bowel frequency. Some patients complaining from diarrhea. Biliary colic is typically present in 10 to 25% of patients associated with nausea, vomiting. Pain may radiate to the chest. So any patient with the biliary colic should send to the ECG because there is similarity between MI and biliary colic or pain of acute cholecystitis. The pain is usually severe and may last for minutes or even several hours. Frequently, the pain starts during night, waking the patient from the sleep. Another presentation is dyspeptic symptoms may coexist and may be worse after such an attack. As the pain resolves, the patient is able to eat and drink again. When the symptoms does not resolve, but the progress to continual pain with fever and leukocytosis, so the susceptibility or the diagnosis of acute cholecystitis should be considered. What are the effects of the gallstone? The effect of the gallstone will be to the three types of the anatomy: on the gallbladder, on the bile duct, on the intestine. The effect of the gallstone on the gallbladder, either asymptomatic, which is common, or causing biliary colic, or causing acute cholecystitis. And this acute cholecystitis, when treated or when resolved, may form chronic cholecystitis. If the acute cholecystitis not resolved and not respond to the treatment, may convert it to the empyema of the gallbladder, pus inside the gallbladder, or mucocele, which is dilatation of the gallbladder with the mucus material without infection, called the mucocele. ومثل ما قلنا انه الميوكوزا of the gallbladder supplied by goblet cell that secrete mucus to an rate of 20 ml per day. So mucocele is one of the complications of the stone that obstruct the gallbladder without infection, called the mucocele. Perforation, which is rare, of the gallbladder due to stone. On the bile duct, the second one, may cause biliary obstruction, slipping stone from the cystic duct, the duct of the gallbladder, that go to the bile duct, obstruct the bile duct, causing obstructive jaundice. When this obstruction associated with the infection lead to the acute cholangitis and may lead to the acute pancreatitis, called gallstone pancreatitis. Third aspect to the intestine, which is very, very rare, a big gallstone may erode the mucosa or below wall of the gallbladder and the wall of the duodenum to go to the intestine, causing intestinal obstruction, called gallstone ileus. What are the differential diagnoses of cholecystitis? Common should be differentiated from acute appendicitis, but it is very easy to differentiate clinically acute cholecystitis from appendicitis, and then should be differentiated between the acute cholecystitis and perforated peptic ulcer. Also should be differentiate acute cholecystitis from acute pancreatitis. Uncommon differential diagnosis like acute pyelonephritis, myocardial infarction مثل ما قلنا لكم, ونيمونيا especially lower lobe pneumonia. What about the diagnosis? Okay. The diagnosis of the gallstone is based on the history and physical examination, mainly clinical. In acute phase, the patient may have right upper quadrant tenderness is exacerbated during inspiration by examiner right subcostal palpation called Murphy sign. When we press on the right subcostal area, especially on the angle between the right subcostal and rectus sheath, here the fundus of the gallbladder. And when I press on, the patient catches the breath, called Murphy sign. A positive Murphy sign suggests acute inflammation and may be associated with the leukocytosis and moderately elevated liver function test. Sometimes the liver function test will be elevated due to edema rather than due to obstruction. A mass may be palpable as the omentum wall of inflamed gallbladder. A policeman of the abdomen will go to any area of inflammation, omentum, that wall the gallbladder stone will be slipped back to the gallbladder and the inflammatory process will be resolved completely. If resolution does not occur, embayement of the gallbladder may result. The wall may become necrotic and therefore may occur with the development of the localized peritonitis. سمعوني شباب؟
نعم دكتور واضح.
واضح تسمع؟ نعم. If the resolution مثل ما قلنا ممكن يصير bus inside the gallbladder, ممكن perforate and necrosis of the gallbladder. طبعا perforation is very rare بالمقارنة بالperforation of acute appendicitis وبيها سبب. ليش؟ لأنه الgallbladder is a distendable organ. في حين الابندكس it is a tubular structure not distended more than 10 مليمتر and ممكن يصير perforation بسرعة أبو الابندسايتس. لكن الgallbladder it is very rare to be perforated because it is a distendable organ. Abscess may then perforate into peritoneal cavity, may cause acute abdomen with generalized peritonitis if the abscess of the gallbladder will separate to the abdominal cavity. نجي على التريتمنت. اوكي عفوا. palpable non-tender gallbladder اللي هي mass that forming by omentum usually result from distal common obstruction secondary to the result from acute cholecystitis. But palpable non-tender gallbladder corvisor sign usually from the common bile duct obstruction that usually due to pancreatic malignancy. Okay, يعني إذا palpable tender acute cholecystitis, palpable non-tender خلي بالك ممكن acute obstruction to the bile duct due to malignancy. But rare non-tender palpable gallbladder due to distal obstruction without infection اللي هو الميوكوسيل. Okay, that should differentiate between malignancy and the mucocele of the gallbladder. What are the treatment of the acute cholecystitis? or biliary colic or gallstone. It is safe to observe the patient with asymptomatic gallstone. When the patient have gallstone but asymptomatic, the conservative treatment follow-up with cholecystectomy only being performed in patient with asymptomatic gallstone. In patient of the asymptomatic gallstone, the cholecystectomy may done in case of prophylactic cholecystectomy should be considered in diabetic patient or in those with congenital hemolytic anemia and those due to undergo bariatric surgery for morbid obesity. يعني cholecystectomy الاسيمتوماتيك patient يمتى اسويها؟ يمتى يكون اذا patient A اللي هو diabetic اللي هو hemolytic anemia اللي هو bariatric surgery اللي هو for morbid obesity، لان كلهن انه المريض ما متاذن للجولستون لكن اسوي له cholecystectomy اذا عنده ذن الشغلات. اما اذا ما عنده ذن الشغلات follow up and observation. نيجي على for patient with a biliary colic يعني عنده symptoms or cholecystitis. Cholecystectomy is the treatment of choice in absence of the medical contraindication. But الاختلاف فين؟ timing of the surgery. يعني احنا متفقين انه symptomatic gallstone يراد له cholecystectomy والاكيوت cholecystitis يراد له cholecystectomy، لكن الاختلاف وين؟ بالتايم اوف سيرجري. اكو ناس تقول لا انا اسوي early operation يعني within 72 hours اسوي cholecystectomy. اكو مدرسه ثانيه تقول لا اسوي conservative treatment ادخله واعطيه conservative treatment then surgery after next available list يعني تقريبا ورا 6 إلى 8 أسابيع. واضح؟ الا اسوي له cholecystectomy. نيجي على المدرسه الثانيه اللي هي conservative treatment then surgery. More than 90% of cases the symptom of acute cholecystitis subside with the conservative treatment that include null by mouth, intravenous fluid administration of analgesia, and blocked. In most instances, the concentration of the antibiotic within the serum is more important than concentration in the bile. Metabolized to the serum, not excreted in the bile, because عادة there is obstruction to the gallbladder. ما يوصلها الانتيبيوتيك إذا عن طريق البايل. So the broad spectrum antibiotic effective against the gram-negative aerobe is most appropriate like cefazolin, cefuroxime with gentamicin. Okay. 4 subsequent management when the patient becomes stable like temperature, pulse, the patient subside. Oral fluid will be reinstated, followed by regular diet. Ultrasound will be performed to ناس كل ورا 6 إلى 8 أسابيع variable لكنه ما نسويها within the admission. واضح؟ المدرسة الأولى تقول لا أسوي routine early operation within the same admission we do operation is undertaken within 5 إلى 7 days of the onset of the attack of acute cholecystitis. The surgeon experience should be present and excellent operating facilities should be present to do early operation. If an early operation is not indicated, wait 6 weeks for inflammation to subside مثل ما قلنا conservative treatment و delayed operation. واضح؟ نيجي على treatment or discuss the complication of acute cholecystitis like empyema of the gallbladder. The gallbladder appear to be filled with pus. It may be sequelae of acute cholecystitis or as a result of infected mucosal. The treatment is drainage and later cholecystectomy. Drainage and later cholecystectomy. يعني drainage of pus later on we do cholecystectomy. Another subject which is rare طبعا called acalculous cholecystitis, which which is inflammation of the gallbladder not due to stone, called acalculus. Due to stone, called calculus. Acute and chronic inflammation of the gallbladder can occur in absence of the stone and give rise to clinical picture similar to the calculus cholecystitis. Acute acalculus cholecystitis is seen particularly in patients recovering from major surgery like coronary artery bypass, major cardiac surgery, calculus cholecystitis is the same like calculus cholecystitis. There is a group of conditions that occur in gallbladder other than gallstone called cholecystosis that include polyposis, adenomyomatosis, and cholecystitis glandularis proliferans. This is a group not uncommon but occur in the gallbladder. This is not a common group of the condition affecting the gallbladder in which there are chronic inflammatory changes with the hyperplasia of the all tissue element of the gallbladder. Cholestrosis, someone strawberry gallbladder. In the fresh state, the interior of the gallbladder look like strawberry. Cholesterol polyposis, the polyp of the gallbladder during cholecystography show negative shadow in a functioning gallbladder, or there is well-defined polyp present in the ultrasound. The well-defined echogenic shadow within the gallbladder that not change with the movement of the patient, because the echogenic shadow that change, and stone, that the echogenic shadow inside the gallbladder that not change in the position of the patient, mean polyp. Surgery is advised only if they change in the size or are longer than 1 cm at the first diagnosis. يعني surgery of the polyp اللي هي cholecystectomy indicated when the size of the polyp is larger than 1 cm from the start or increase in the size after follow-up. Cholecystitis glandularis proliferans اللي هو polyp, adenomatosis, and intramural diverticulosis. A polyp of the mucous membrane is fleshy and granulomatous. All layer of the gallbladder wall may be thickened, but sometimes incomplete septum form that separate the hyperplastic from the normal. Intraparietal mixed calculi may be present within this diverticuli. This can be complicated by intramural, later extramural abscess. If the symptomatic patient, the treatment is cholecystectomy. Diverticulosis of the gallbladder, when the gallbladder wall supplied by multiple diverticuli, مثل tube, is usually manifest as black pigmented stone impacted in the outpouching in the wall of the gallbladder. Diverticulosis of the gallbladder may be demonstrated by cholecystography, especially when the gallbladder contracts after a fatty meal. There are small dot of contrast, medium. Just for this condition is cholecystectomy. We discussed the cholecystectomy. How do the cholecystectomy? Cholecystectomy, you should prepare patient for this operation. By appropriate history should be taken. Patient fitness for surgery or for this procedure should be assessed. They include investigation of the cardiovascular, respiratory system, and full blood count, like biochemical, and performed to exclude anemia, because the anemia is very important in pathogenesis of the gallstone. مثل ما قلنا ممكن هو hemolytic anemia, abnormal liver function. Blood coagulation is checked if there are history of jaundice. The patient is often prophylactic antibiotic, either a pre-medication or at time of anesthetic induction. A second generation cephalosporin will be appropriate. Should take measure to prevent DVT, subcutaneous heparin or anti-embolic stocking should be prescribed. informed consent should be taken. تشرح للعمليه ممكن شنو الاوبشنز، ممكن شنو اذا مو عمليه شنو ايش راح يصير، ممكن انه complication of surgery لازم تشرحها للمريض بما فيها الياتروجينيك انجري. اوكي، رغم هي very very rare. Nowadays the cholecystectomy usually done for cholecystectomy are the same to that done by open technique or laparoscope. Same the principle. The laparoscopic cholecystectomy is the procedure of choice nowadays for the patient. Serious complication of the laparoscopic cholecystectomy should be known that fall on two major areas. Excess complication usually by of the establishment or the insertion of trocars. If the insertion is performed blindly or is found to be difficult, visceral injury should be excluded. If there is either visceral or bile duct injury is suspected, conversion to the open technique is recommended by most surgeons. Okay. With whom laparoscopic approach is not indicated or on whom conversion from the laparoscopic approach is required. يعني مثلا difficult operation وقرر الجراح انه يحولها من laparoscope to the open cholecystectomy. بهاي الحاله اللي نقدر هاي الحاله اللي ممكن نسوي open cholecystectomy اللي هو nowadays is rare because the laparoscopic surgery is widely used. Cholecystectomy cholecystectomy اللي هي opening of the gall bladder, just not removal of the gall bladder, is rarely indicated, but if necessary, as many stones are possible should be extracted and large folic acid direct tract extension of the gall bladder through opening in the fundus called cholecystectomy. ونخلي بيها تيوب اللي هو عادة فولي 14F that placed in the fundus inside the gall bladder to drainage the gall bladder. Okay. Indication of choledochotomy يعني choledochotomy هو opening of the bile duct or exploration of the bile duct during cholecystectomy. It is nowadays very very rare to explore the bile duct because the availability or widely used ERCP اللي هو endoscopic retrograde cholangiopancreatography that deal with any abnormalities of the bile duct make the choledochotomy اللي هو operative dichotomy is very rare. Now previously there is indication of choledochotomy when there is palpable stone in the common bile duct during the procedure of the cholecystectomy. We should open the bile duct. When there is jaundice, history of jaundice or cholangitis, we should explore to the bile duct to know what is the cause of this jaundice. 3. Dilated common bile duct. During cholecystectomy, we discover there is dilatation of the bile duct. We know the diameter of the common bile duct is 3 to 8 ملم. When it is dilated, that discovered of the by surgeon, it is dilated about 1.5 cm, يعني 15 ملم. It is dilated. You should explore the CBD for any cause of this dilatation. Abnormal liver function test, and particularly raised alkaline phosphatase, especially alkaline phosphatase, because the liver function test composed of bilirubin, direct or indirect, and liver enzymes, ALT, AST, to exclude obstructive jaundice. The alkaline phosphatase is usually important in case of obstructive jaundice. Okay, لهذا القصد نخلص من المحاضرة الثانية that related to the biliary. بعدين المحاضرة الثالثة ناخذ obstructive jaundice و management of the bile duct dilatation and management of the bile duct obstruction. اوكي، وممكن نبدي بالليفر اللي هو محاضرتين، يعني بعد لي 3 محاضرات اخلص لكم الليفر اند بلياري. اوكي شباب، اللي عنده سؤال يسال اذا الصوت واضح.
دكتور كاراليز ديسيز